The muscular system. Sometimes the system that massage therapists think is the most important for them to learn, but I would challenge that. Yes, it's often what we're targeting in terms of client goals. Reducing the tension in muscles, for example. Improving the flexibility of muscles. Reducing the pain, perhaps. So our goals can be muscular, but actually what we're targeting might be the nervous system. So as we go through each module in the Anatomy and Physiology program, start to piece together how, as manual therapists, we are stimulating many systems across the body to achieve results, perhaps, in the muscular system, but how we utilize things like the nervous system to generate those results. So what are the functions of the muscular system? We'll start with the most obvious, movement. So the muscular system is responsible for the movement of the human body. Muscles attached to the bones of the skeletal system, for example, over 700 named muscles, each its own discrete organ constructed of skeletal muscle tissue. It has its own vascular blood vessel supply, tendons to connect it to bones, and nerves innervation to make them contract and relax, for example. They don't contract all at once, rather they blend together, and the fascia and connective tissue helping them to create this subtle, dynamic and enormous ranges of motion that we can see in the body. Joint stabilization. So again, we may not be moving, maybe we need to stabilize joints, but again, the muscles who cross across those joints can contract without lengthening or shortening to help us stabilize those joints. Posture, how we hold ourselves, whether at rest or in activity, on standing, at work. Our muscles are what allow us to create the postures we need for our activities of daily life. Heat generation. As we contract, relax, as that pumping around the body and integration with other systems, heat is generated as a byproduct. It doesn't take long warming up for you to feel that function. Heart function. The myocardium, the muscle of the heart. It's muscle that allows this beating of the heart to pump blood around the body. The flow of fluids and food. Again, that contraction and relaxation, conscious and unconscious, that allows the flow and the passage of these things through the body. We'll talk about how movement, contraction and relaxation of the muscles of the body help and assist lymphatic flow in the body, for example. And how the autonomic subconscious contraction via peristalsis helps in digestion, helping move that food down the esophagus into the stomach and down into the intestines. Excretion. Bowel or bladder, again, it's the muscular system that allows us to excrete from the body. So let's talk about the three different types of muscle tissue, which are quite individual and perform differing functions. And that will make it clearer which type of muscle creates the functions we've just talked about. The first type being cardiac muscle here. So this is located in the walls of the heart, and it's striated in appearance and under involuntary control. So you don't have to consciously tell your heart to beat every time we need it to beat, which could be anywhere from 55 to 70 beats in a minute, for example. So it's a good thing that it's autonomically controlled by the nervous system. It's operated by single nucleus, and cardiac cells rely almost entirely on aerobic metabolism. We cannot afford for the heart to run out of energy. And therefore it has large numbers of mitochondria for energy and high concentrations of oxygen-carrying myoglobin. On the downside, cardiac muscle tissue does not regenerate. And this is why diseases like heart disease can be so high risk. Cardiac muscle cells are myogenic, so they're individual cells that contract at a regular frequency without any external neural stimulation. And when we come to the cardiovascular system, we'll talk about the sinoatrial node, which is our natural pacemaker, which helps in that process. It also does co-contraction. So the contraction of one muscle fibre within the heart will stimulate contraction of the neighbouring cell, helping to keep this constant, rhythmical, consistent beating of the heart. Now let's move on to skeletal muscle, the most common muscle tissue in the body. It's located in all skeletal muscles of the body, and again it's striated in appearance. It has many nuclei in each fibre, as we can see here. And it's mostly under voluntary control or conscious control. You will consciously tell your arm to pick something up off a table, for example, resulting in the contraction and relaxation and muscle movement sequences of that action. It's generally attached to bones via tendons, some to skin or the deep fascia, or even blending into other muscles. But the contraction and relaxation of these skeletal muscles is what produces skeletal movement, walking, running, jumping, using your mouse, typing on a keyboard, all of those conscious actions that we do each day. Postural muscles maintain the body in stable positions, and their physiology is slightly different to help deal with those situations and to have the longevity and the energy to perform those postural movements. Skeletal muscle cells have a limited capacity to regenerate. The cells cannot divide, but they can heal, so muscle injuries can be recovered from. Now, smooth muscle here. So this is located in the walls of the hollow visceral organs of the body, the blood vessels, capillaries, and the digestive tract. So rather than striated, they are spindle-shaped. And they have many nuclei in each, one nuclei in each spindle-shaped fibre, as we can see here. So they're mostly under involuntary control. They are controlled subconsciously by our nervous system. They tend to contract with a peristaltic wave action called peristalsis. And this waving action of contraction and relaxation is really useful for moving and transporting things around the body, whether it's food, urine, or blood. And smooth muscle regenerates easily. So let's talk about some of the key terms that are used when talking about the muscular system. And we'll start with the origin and insertion. So generally, in most cases, one end of a muscle is fixed while the other moves to create movement. The origin is the attachment site that doesn't move during contraction. The insertion is the end that moves. So going back to that pectoralis major that we just talked about, and we talked about how the sternum and clavicle don't tend to move very much when the pectoralis major contracts. But what we do see is greater movement on the insertion end, on the humerus, so at the glenohumeral joint. So the insertion is generally the end that moves. Action. The action is the resulting movement or movements, as muscles sometimes have many movements available to them. That happens when the contraction of a muscle takes place. For example, flexion. Innervation. This describes the nerve that controls that muscle. Muscular fatigue, and this is around energy when we're talking about muscular system. Tone, this is the resting tension in a muscle. Tone in a muscle stabilizes the position of the bones and joints at rest, whereas tension is usually used to describe the force that results from muscular contractions. So when a muscle is under tension, helping us to lift something, for example. Whereas resting tone is the tension when we're not moving or lifting. So here are the key terms that are used to describe how a muscle is behaving under movement. And the first one we'll talk about is the agonist, the prime mover. So this describes the muscle that provides the major force to complete the movement. For example, the flexion of the elbow. Here, the agonist in this flexion at the elbow in a bicep curl would be the bicep. The antagonist. This is the muscle that acts in the opposing manner to the agonist. It can be used to slow down or control a movement, or even stop a movement. So here, in this example of a bicep curl, the antagonist would be the tricep muscle. We then have the synergists, and this is a word used to describe a muscle or group of muscles that work together with the agonist to assist in the action or movement. For example, the brachialis in the flexion of the elbow. We then talk about fixators. And again, this is a muscle or group of muscles that stabilize the origin of the agonist to enable it to act more efficiently. So here in the example of a bicep curl, this could be the rotator cuff, which is stabilizing the head of the humerus in the glenohumeral joint, allowing the bicep to produce more force in its flexion at the elbow. So agonist, prime mover, antagonist, opposing mover. This synergist is the helper, the assistant, and the fixator is the stabilizer of the origin. Now let's talk about the three different types of contraction that we talk about and utilize when we're working with clients in a sports massage context. First, let's come back to that bicep example. This shortening of the bicep as it flexes the elbow. So where we have contraction of muscle fibers that results in shortening, this is called a concentric contraction, where the muscle fibers shorten as they contract. Eccentric loading here. So where a muscle is contracting, but it's lengthening. If we're lifting and flexing a heavy dumbbell, if we just completely relax the bicep, well then that dumbbell might hit the floor, causing damage or injury to ourselves. Whereas the bicep can act in a controlling manner, where it's contracting but lengthening. And this is what we describe as an eccentric contraction. We then have isometric contraction of the skeletal muscles. And this is where I'm holding that dumbbell, not moving my elbow, maybe psyching myself up for that next rep. And this is where there's no change in length of the muscles as they contract, but they are contracting to stabilize or hold a position. So for example, me holding that dumbbell on my outstretched arm here. Or if we come back to the previous slide where we talked about our fixators, the rotator cuff stabilizing the head of the humerus in that joint, they would be acting in an isometric contraction. So contraction of the muscle fibers where the length does not change. We're now going to look at the physiology and the anatomy of the muscles themselves, right down to a cellular level. So we're going to zoom in here, starting at the biceps, which is bulging, it's contracting, and look right down to these thin and thick filaments that are used to start the contraction process. So the muscle. The muscle has an outer layer of connective tissue called the epimysium. This outer covering of the muscle surrounds several bundles of muscle fibers. So we can see here one of those bundles. Each of those bundles, which are within the muscle tissue, is surrounded by its own connective tissue, and this is called the perimysium. And this is wrapping many fibers that are bundled together. Then, within each muscle fiber, we have another sheet of connective tissue called the endomysium, and this surrounds each muscle fiber. And the endomysium is continuous with the fiber's membrane, which is called the sarcoplasmic reticulum. and it is responsible for the release of calcium, which is key to the sliding filament theory that we're going to talk about, that creates the contraction in a muscle. So as we come into each muscle fibre, we have what is called a myofibril. And each muscle fibre has a number of myofibrils, and these are the smallest contractile unit of the muscle. It's a cylindrical organelle that runs the length of the muscle fibre, and it is made up of sarcomeres. A sarcomere is the functional unit, and it contains actin, the thin filament, and myosin, the thick filaments. These two filaments are key to the muscle contraction process. So we've talked about how we go from the muscle right down to these functional units, the sarcomeres, and how the connective tissue connects them from that outer layer of the muscle right through each bundle, right down to each muscle fibre. But it goes beyond that, because each muscle is attached to something, to a bone, to a joint. So the epimysium and the perimysium, again, they're collagen tissues, but it's more irregular collagen fibres. But the collagen fibres become more regularly aligned and thicker as the muscle connects into tendon. The tendon, so this thick, dense, regularly aligned connective tissue, fuses with the periosteum, which we talked about in the skeletal system, the connective tissue, that outer coating of the bone. All the connective tissues in a muscle are continuous with each other. It is this connective tissue that transmits the pulling forces generated inside the muscle cells to the bony levers, bringing about movement. It is the connection to those bones that allows the contraction within a muscle to generate movement. In addition, all muscles are well supplied with blood vessels carrying nutrients, oxygens, and nerve fibres. And these nerves help convey the stimulus for the contraction. So now let's deep dive on how the contraction happens in these sarcomeres to result in that contraction of the biceps in this example. So we're going to talk about the physiology of creating a muscular contraction. And here we're working right down in the sarcomeres, so right down in a functional unit. And we're going to look here at the thin filament, actin, and the thick filament, myosin, that we drilled down to in the last slide. Now don't get too bogged down in this. I will describe to you what's happening, but in the next slide you'll watch a short video that has a really good animation that shows this process. And if you're a visual learner, it may make more sense as to what is happening. So, it all starts with a message from the nervous system. So when a nerve message stimulates a muscle fibre, calcium is released from its membrane, the sarcoplasmic reticulum. This calcium reveals a binding site on the actin filament. And this is what helps the myosin head to attach. So the calcium attaches to troponin here, and that is attached to the tropomyosin, which then allows the myosin heads to raise up and attach to the actin molecules. So this attachment is what's called a cross bridge. The myosin head then pivots and bends, and you'll see this illustrated quite nicely in the animation upcoming. And this pivoting and bending pulls the actin filament over the myosin filament towards the center of the sarcomere. The myosin head then detaches from the actin, but it's ready for the next one. It relaxes back to its original position and prepares to attach to the actin again, but this time further down the filament. So it's constantly moving, creeping along that thin filament, pulling it towards the center of the sarcomere. The myosin walks along the actin, progressively pulling each filament towards the middle. And in this way, we get the shortening in the muscle, without any change to the overall length of the myosin or actin filaments. But we can get this shortening and contraction in the muscle tissue. This process happens extremely quickly, and there are over 600 myosin heads in a simple myofibril filament, attaching and reattaching about 5 times every second. So we're getting a attach, pull, attach, pull, attach, pull, attach, pull, 5 times per second, but happening in over 600 myosin heads in one fibril. So although this seems like a very simple, very small process, when it's happening on that scale, it results in the large-scale contraction that we see within a muscle. At any one instant, some of the myosin heads are attached to actin, generating force, whereas others are waiting, ready to bind again. And this is what we call a contraction cycle, or sometimes it's referred to as the sliding filament theory, as it describes how the actin thin filament, myosin thick filament seem to slide along each other to create contraction. Now, it's important to note that each individual muscle fiber, when activated or recruited by the nervous system, that they will work to their own maximum potential. It's all or nothing. They'll have a force they generate when they are recruited or not. But this doesn't mean that every time you contract your bicep, for example, that the same force is generated. It depends on how many muscle fibers are recruited, for example. But this principle that each muscle fiber, once recruited, will always work to their own maximum potential is what is called the all or nothing principle. So let's talk about calcium for a moment. So we talked about how calcium kick-started this process. So the calcium released from the membrane, the sarcoplasmic reticulum. It is the releasing of that calcium that reveals the binding site on the actin that allows the myosin head to connect, creating the cross bridge. A single ATP molecule, adenosine triphosphate molecule, ATP, is used up every time a myosin head pivots and pulls on the actin filament. So for this contraction cycle to occur, muscles need a continuous supply of both calcium and energy, and it comes in the form of ATP. So calcium to release and reveal the binding site, and energy in the form of ATP. Muscle cells carry their own store of calcium, and it's constantly, continuously being replenished from the blood. It gets replaced, it replaces its reservoir from bone if dietary intake is inadequate. And that's why it's really important that we consume calcium, because we don't want the blood to take that calcium from our bones, weakening them, to allow for muscle contraction. So let's take a look at how this contraction occurs in an animation. Hopefully it will become clearer what happens, and I want you just to focus on those key points. I want you to focus on the release of calcium, the ATP, the actin connecting with the myosin pivoting and bending, pulling on the actin, and the repeating of this action, the sliding of the filaments, to create the movement. It might be worth looking at the video and then maybe reading through the theory in your handbook to make sure that you can make sense of it and that you're clear on the mechanisms involved. Okay, I want you to pause the lecture here, and you're going to go to YouTube. So you won't be able to click this link from your video. So I want you to write it down, and then you're going to type it into your browser window. And I want you to watch this short video on the sliding filament theory. I think it will give you a great visual as to how this happens and hopefully help you understand the key points that we've just talked about. So hit pause, take those 5 minutes, and then come back here and we'll continue the rest of the module. Tendinopathies. So So this is a generic descriptor or grouping for clinical conditions of the tendon, so that attachment of the muscle to the bone. And it is where there is pain and or pathology in that tendon. It can often be associated with overuse and repetitive strains, and it describes where there's a degeneration of the collagen in the tendon. Now, there are many pathologies for tendons with different names, like tendinitis, tendinosis, and they have all been grouped into this tendinopathy, as tendinitis really just describes inflammation of the tendon, but doesn't describe the condition of the collagen protein within that tendon, for example. So it's more modernly known as tendinopathy, as this group or generic descriptor for issues in the tendon. So if your client presents with a tendinopathy, that might be an Achilles tendinopathy, rotator cuff, or golfer's tennis elbow, you can definitely treat these clients, but what you need to do is treat that tendon as a local contraindication. We don't want to work directly over tendons, especially not if your client is in acute pain. We're not qualified as level 3 massage therapists to treat injuries or acute conditions, but we can absolutely work in the soft tissues and the muscles that attach into these tendons. And often doing soft tissue work to the muscle belly can have an impact on the pain that is felt at the tendon. Cramp. So cramp is an involuntary contraction of the muscle, and it's generally accompanied by pain. They're short-lived, acute contractions, and they're most commonly found in the calf muscles, for example. They commonly don't last very long, but your clients may present with common or frequent cramps in a part of their body. So if a client is having an acute cramp, then massage would be contraindicated during that cramp. Once the cramp has subsided, then stretching and massage will help to relax the muscle tissue. But again, we need to start understanding why this client is getting repeated cramps. If there's no improvement for your client, refer them on to a GP for further investigation, as sometimes mineral imbalances can cause cramping too. Strains, muscular tears or strains. Again, different varieties of these. As a level 3 sports massage therapist, you will be contraindicated from treating an acute injury, an acute strain. So if that client is in that first 48 to 72 hours in acute pain, then that would be a contraindication for you. But often you will have clients come to you who are a week, 2 weeks, 3 weeks post-strain, who may be having issues with stiffness, restrictions in range of motion, and some dull chronic pain. So in this case, you can absolutely treat your client. But if that client presents with an acute injury that they received in the last 48 hours, then it's a local contraindication. So avoid that area, for example, if it was a calf strain, but you could absolutely do some work to the other parts of the body more globally, which may help with preventing things like compensation patterns or tension in the wider body. In terms of symptoms, red flags to look for is any visual swelling, redness, clamminess of the skin, and any fresh bruising, for example. So a client may forget to tell you they have an injury, so it's important that you also do a visual assessment. Your client may have pain when using the muscle on contraction, or they may not be able to use the muscle at all. If you suspect an acute injury, please refer your client to a physio or osteopath, or even their GP for diagnosis and treatment. So fibromyalgia, something which seems to be becoming more common these days, and this is a chronic, widespread body pain, and these people tend to be very, very tender. They're very sensitive to that pain, and they also tend to suffer from exhaustion, tiredness, stiffness, very, very complicated and draining condition. So it's not clear on the cause at the moment. It's believed it might be environmental, lifestyle related, potentially a problem with the central nervous system, or maybe it's even genetic. It's also been seen to be triggered after trauma, for example, or severe infections of the body.
And it looks like the research is saying that massage is helpful, but we need to be really, really careful with these clients, that our pressure is very light, that we're talking to those clients, we're working through pressure levels with them, and really working with them to produce a result that's positive for them. Next up is muscular dystrophy, and this is a progressive wasting and weakening of muscle tissue. Again, that can lead to fatigue, exhaustion, vision problems when the muscles of the eyes are involved, and it can also affect the heartbeat because, again, that's muscular. So we can treat people who suffer from muscular dystrophy, but it needs to be gentle, and we need to look at our purpose. What is our purpose? We're not going to fix this condition. So we're looking at pain relief, stress relief. We're trying to make these clients feel better. And I think bearing that in mind, working with your client, modifying your pressure, you will make a really, good impact for that client. And I think it's with every massage we do. It's why we question people. It's why we want to understand their history, because with every treatment, you need to ask yourself, what is it we're trying to achieve? And agreeing those goals with your clients. And then we have myositis. So this is a very rare condition. I certainly haven't come across this. And literally it means inflammation of the muscles. So it's signified by muscle weakness, very painful, aching muscles. People tend to trip, fall, very tired, and can't really do much in the way of exercise when they're suffering from this condition. It's generally caused by an underlying problem with the immune system, and your immune system starts to attack healthy muscle tissue. But again, there are other causes that can happen. Massage can help relieve some of the symptoms, but you want to be working with the client and their GP to make sure that it is indicated, that there's no reason or underlying reason why massage shouldn't be done. And again, what is our goal? We're trying to make these people feel better. We're trying to relieve some of the pain, some of the stress, some of the stiffness that they're experiencing. So we want to modify our pressure, make sure we're keeping them pain-free, keeping them supported, and helping them to feel better.
So what does all this theory on the muscular system mean for massage? I think right now we need to separate the two, the benefits of massage and the physiology. There is a lot of evidence that there are benefits to sports massage. The why they happen is still unclear, and we'll talk about this in Module 13, Sports Massage Physiology. There are also a lot of claims made about the benefits of massage that are untrue and have been unfounded. So we need to be very careful about the claims that we make. Where we know there's a benefit to massage, let's communicate with our clients. But let's not get caught up in all the massage myths that are out there. In terms of the why, again, we do not know. But there are current models that are looking at it being a neurophysical response, that really we are working with the nervous system when we touch our client, rather than making mechanical changes to the soft tissues underneath. Hopefully, future research now looking at this model will bring some clarity as to why we affect the muscular system in the way we do with manual therapy. So some of the evidence that we do have relating to the soft tissues themselves. Research has shown that manual therapy can increase range of motion, so improve flexibility. Massage has been shown to reduce pain and muscular tension in a number of MSK complaints, including lower back pain, and also muscular tension associated with psychological things like anxiety and stress. Studies have also shown that massage can help in post-exercise recovery from fatigue, post-exercise strength, and there's even a small impact in reducing DOMS.